It is our great pleasure to introduce you to SICOT Pioneer. Pioneer is a program of innovative orthopedic networking, e-learning, education, and research that was designed to fill the gap left by the absence of face-to-face meetings, courses, and other activities during the 2020 coronavirus pandemic. But Pioneer has become so much more than this in the intervening year. Pioneer is a virtual, but also very real community of like-minded orthopedists striving to help not only themselves, but one another. With the latest video conferencing and educational technology, as well as a groundbreaking online platform, SICOT's Pioneer events, activities, and resources are reaching every corner of the globe, with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Good morning, everyone. I am Tatiana Guerschman from São Paulo, Brazil. It's a pleasure to welcome you all to our Rehabilitation in Orthopedics webinar. this morning here in Brazil, or afternoon or evening, depending where in the globe you are, will be about the comprehensive cervical myelopathy. And we have faculties from all over the world here with us. So we'll leave the questions for the end and the closing remarks. So I will call our first presenter is Dr. Sakti Prasad Das. He's an orthopedic surgeon, and he's also completed his DNB in physical medicine and rehabilitation. He's a dedicated pediatric orthopedic and deformity correction surgeon. He was the recipient of the Henry Benselhel Award at our last SICOT meeting in 2025. And he will talk about the introduction and diagnosis of cervical myelopathy. Please, Dr. Das. I think...
Is it visible now? Yes, okay. Thank you. Thank you. It is an opportunity. And good morning, good evening, and good afternoon to all my friends throughout the world. And today I welcome you all to this webinar. And my topic is Introduction and Diagnosis of Cervical Myelopathy. Basically, it is a spinal cord compression at the cervical level of the spinal column, which results in spasticity. Spasticity means muscle contractions, sustained muscle contractions, hyperreflexia, and pathologic reflexes mainly affect the digit and hand clumsiness or sometimes gait disturbances. And most importantly, it is insidious onset with functional decline. Basically, the pathology picture and MRI looks this type of spinal cord at the cervical spine level. It is compressed from various sides, leading to all the upper motor neuron lesions in the upper limb and lower limb. If you see the etiology, most common cause is degenerative cervical spondylomyelopathy, which we'll discuss mostly today, and moreover traumatic, congenital, and developmental. Some vascular causes are there, which is very acute onset. Neoplastic sometimes slowly it affects the spinal cord. Some infections and also inflammatory conditions. If you see the myelopathy versus stenosis, in the cervical spine, patients are more predisposed to myelopathy due to a congenital narrowed spine cervical canal. Subsequent progression of stenosis also occurs due to cervical disc herniation. Degenerative changes usually occurs at C5 and C6 or C6 and C7, mostly due to the increased mobility of that part of the cervical spine. If you see pathology, basically disc and facet joints. These are the most important cause. Ossification of the posterior longitudinal ligament, sometimes ligamentum flavum hypertrophy or ossification, facet joint arthropathy, which is a degenerative condition, disc herniation in multiple levels. In some population, congenital canal stenosis, osteophyte formation, trauma or instability, tumors or cysts causing cord compression. So basically, these are the pathology involving the spinal column of the cervical region. Most common cause of spinal cord dysfunction in adults. Incidence is 4 per 1 lakh annually. Prevalence, it will see it increases with age due to the degenerative changes. Predominantly, it affects the males more than females. Approximate ratio is 2:1. Onset typically in the 5th or to 7th decades of life. Higher prevalence in individuals with the physically demanding occupations. If you see Asians, they have increased risk of cervical myelopathy due to the increased prevalence of the ossification of the OPLL. So risk factors are aging, that means more age is involvement, chance of myelopathy is more. Those who have congenital narrow cervical canal, repetitive micro trauma, genetic predisposition, mainly Asian population, occupation involving neck stress or vibration or exposure, computer professionals. So your age is the strongest predictor of morbidity and unfavorable neurological recovery. Symptoms mainly affect the upper extremity, initially complaints of hand clumsiness, limited ability to perform fine motor tasks such as buttoning of the shirt, combing of the hair, holding small objects, and difference of coin sizes. These are the initial symptoms which patient may not know it. Lower extremity, person starts ambulating the wide waist gait as if he will fall, and sometimes feel weakness, complain to us with weakness. And neck pain, radicular symptoms are common, but they may be also very early features. Lermit sign, I will come to it. And toward the end, when the compression increases, there may be bladder or bowel dysfunction with general weakness. We have to examine the patient. History taking is important. Pain, radiation of pain, and inciting events. Physical examination, neurologic examination, motor, sensory, arms, legs, bladder, bowels, in detail. We have to do the clinical examination. You have to evaluate the muscle power, get the muscle power grades, sensory area, various other reflexes. And we examine the skin along the back of tenderness or any prior surgical scars, because sometimes tuberculosis may be there. If you examine upper motor neuron signs below lesion is hyperreflexia, Babinski sign, tonus. These are the upper motor neuron signs we get in upper limb or lower limb below the level of the affection. Lower motor neuron signs are the level of the lesion. In the same level, it is a lower motor. So muscle weakness or atrophy. Suppose C7, C6, C7. So there may be hand muscle atrophy, hyporeflexia, Lermit sign. Lermit sign is electric shock-like sensation when you suddenly do the neck flexion and gait imbalance. So we have to examine the gait. They look like very tight gait or spastic type of gait. We have to examine the gait. We have to examine neurological reflexes, biceps, brachioradialis, patella, Achilles tendon. Sometimes these jerks are exaggerated. Lermit sign, Hoffman sign, cross radial reflex, inverted radial reflex, finger square sign, and grip test. So we have to examine to confirm. So clinical examination is most of the important thing in examination of the person with cervical myelopathy. So neurological examination focus on reflexes, coordination, and sensory deficit. Various sensory scoring systems are there. How much is the involvement? Neuric grade and Japanese orthopedic assurance score are the two important scoring systems to know the severity of the myelopathy involving the muscular part. Modified Japanese Orthopedic Association score involves upper extremity function, lower extremity function, sensory function, and bladder function. So 4 things only. So if severe, then 0 to 11, mild 15 to 17 points. So these are calculated for recording purpose. Neuric classification and run-out classification, 2 classifications, which are basically to know how much the involvement, or whether grade 0 means patient is just started, and grade 5 means wheelchair bound. That means already both upper limb, lower limbs are paralyzed. The electrophysical examination, EMG, nerve conduction studies, SSEP, motor evok potential, those who have modest sensitivity and sensitivity, but it's assisting localization, ruling out alternate diagnosis, and performing intraoperative monitoring. These are necessary. Imaging, X-ray, show the osteophytes, instability, initial is X-ray, sometimes alignment abnormalities, but MRI, gold standard. It visualizes the spinal cord compression, signal changes, and soft tissue pathology. CT scan evaluates the bony structures and ossifications and canal stenosis. CT myelography if MRI is contraindicated or MRI is not available. So X-ray, torque ratio is cervical diameter. MRI, if canal space is less than 10 millimeter, it indicates stenosis. So compression and signal changes on T1 and T2 are indicative of the myelopathic changes. Prognosis depends on severity and duration before the intervention. Early surgical decompression improves the outcome. So how long it has been involved. So delayed management, delayed surgical intervention gives bad prognosis. So long-standing symptoms, severe preoperative deficits, and cord signal change MRI or myelomalacia are bad prognosis. So to MRI, if you see high intensity changes on T2 and low intensity T1, there is a poor recovery rate, worse motor symptom improvements. High ratio of T2 signal intensity between non-compressed and compressed was associated with poor JOA recovery rate. More frequent high signal intensity T2 predicts worse recovery. So learning points of my talk is, so this myelopathy, most common cause of spinal cord dysfunction in adults. It results from progressive degenerative changes causing spinal cord compression and ischemia. Early recognition of symptoms and signs is critical to prevent irreversible neurological damage. MRI remains the gold standard for diagnosis and assessment of cord compression. Prognosis depends on duration and severity of symptoms before the intervention. So these are my references: Bradham's PMR, Rehabilitation Medicine, AO Spine Guidelines. So I appreciate appreciation. Thank you very much.
Thank you very much, Dr. Das. Perfect presentation. We'll move on. Our second talk is non-surgical management strategies by Mohamed Badr. He's a neuromuscular physical therapist and researcher at the Department of Neuromuscular and Surgeries in the Cairo University. And then in the same presentation, Dr. Mariam Ibrahim, she's a member of our Orthopaedic Rehabilitation Committee, as Dr. Das is also a member. I haven't mentioned it, sorry, and Dr. Lam. So we four are members of the Rehabilitation Committee, and I'm the vice chair, and I'm very happy to host this webinar. And Dr. Fabio Schiaretta is our chair, and I'm sure he's here with us. So thank you, Dr. Fabio, for this opportunity. So continuing, we'll have Mohamed, and then following Mariam Ibrahim. She's a member of the Orthopaedic Physical and a member of the Orthopedic and Trauma Surgery at Aswid University in Egypt. So welcome, Mohamed. Please, you can start sharing your presentation.
Hello, good afternoon from Egypt. Now we are talking about the non-surgical management strategy. For non-surgical management strategy, it composed of from physical therapy and OT, and also some pharmacological treatment. We will talk about the non-surgical management in terms of physical therapy and OT. Before we talk about non-surgical management, we need for the clinical grading of cervical myelopathy. For clinical grading, we have 4 grades: non-spondylotic myelopathy, mild spondylotic myelopathy, moderate spondylotic myelopathy, severe spondylotic myelopathy. For non-spondylotic myelopathy, the patient may have only radiological evidence of cord compression without any clinical signs and symptoms of cord compression. The patient may suffer only from root symptoms. For patient with mild spondylotic myelopathy, the patient will have some little clinical signs of myelopathy with imaging evidence of cervical myelopathy. For moderate spondylotic myelopathy, the patient have moderate to severe clinical signs of myelopathy with image evidence. Severe will be clinical in terms of radiological and also clinical terms. As Dr. Das talked, we have two clinical classifications, the NORIC and the Modified Japanese Orthopaedic Association score. The classification from grade 0 to grade 5 depend on the severity. For patients with mild myelopathy, the Modified Japanese Orthopaedic Association will be from 15 to 17. For moderate, will be from 12 to 14. Severe myelopathy will be less than 11. When we talk about the non-surgical management, the candidate for non-surgical management or conservative management will be only patient with non-myelopathic spondylosis or mild spondylitic myelopathy. The physical therapy management for cervical myelopathy will be cervical traction, manual therapy to address the restriction, range of motion, the exercise for weak muscles, especially hand muscles and arm muscles, braces, electrotherapy, gait and balance training. For the candidates for non-operative treatment, there will be only two types of patients that will be good candidate for non-operative treatments: asymptomatic spondylotic myelopathy and mild spondylotic myelopathy. When we compare comparison between the operative and the non-operative treatment for mild and moderate cervical myelopathy, we have greater chance of failure of conservative treatment for patients with mild and moderate spondylitic myelopathy. The chance of failure reach about 50%. When we talk, one research talk about the failure ratio, it's about if patients have more than 13 on modified Japanese orthopedic score, about 23 to 34% of patients ultimately will receive surgery within 2 years. So non-operative treatment management have high rate of conversion to surgical intervention. Patients with mild and moderate cervical myelopathy need close monitoring for symptom progression in the first 2 years after appearance of symptoms. So to summarize the non-surgical intervention, we have 4 grades: asymptomatic, mild spondylotic, moderate spondylotic, severe spondylotic. For patient for good candidate for conservative treatment, the patient with asymptomatic and mild to moderate spondylitic myelopathy, the initial treatment will be physical therapy and observation for 3 to 6 months. For patient with moderate to severe spondylitic myelopathy, it's advised to the initial intervention to be surgical decompression. To summarize the non-operative treatment is the initial management for mild and moderate cervical myelopathy. Non-operative treatment have high chance of failure due to the progressive nature of the degenerative cervical myelopathy. Patients who undergo non-operative treatment should have close monitoring every 3 months to monitor any clinical signs of progression, as early intervention during any appearance of severe clinical signs will predict the functional outcome after surgery. Thanks. Now, Dr. Mariam will continue the second part of the presentation.
Okay, Mariam, just unmute your microphone, please, and then you can continue with the presentation.
Thank you very much, Dr. Badr, for your presentation, and thank you, Dr. Tatiana, for the introduction. I will just continue what Dr. Badr started about physical therapy. Occupational therapy is complementary therapy that goes hand in hand with the physical therapy in cases of cervical myelopathy. And the goal for occupational therapy is to improve the fine hand movement and optimize the daily activities and prevent the secondary complication. First, after the first evaluation of the patient, we start with the patient education. about activity pacing and energy expenditure, decreasing the energy expenditure and using the energy conservative technique, and modified daily task to reduce the pain and increase the endurance. And then we set realistic goals, short goals and long-term goals with the patient, focus on functional independence rather than focusing on the full recovery or strength. We prioritize safety, pain control, and increasing the endurance to complete the independency on activity of daily living performance. And the goals must be measurable. So, for example, we sit with the patient and we say that we, in this amount of time, we will achieve this amount of strength doing this specific activity of daily living. For exercise prescription principles, we do recommend from 3 to 5 sessions a week. It's not fixed number. It depends on each patient presentation, and it depends on the individual variations between the patient for the pre-functional level before the injury and the goals that they aiming to. And the intensity, we start with the low to moderate, depends on the patient functional level, and to avoid the pain and any neurological symptom aggravation. The duration of the session depends on the goals. So it goes somewhere from 15 to 45 minutes, and sometimes we need it to give the patient frequent breaks, depends on the task that they are asked to do. And the type of activities that's done during the session is range of motion, gentle stretching, strengthening, and functional task practice. And here are some examples of the fine hand movement for the occupational therapy that help the patient to get prepared to use the tools for ADLs. We also focus on occupational therapy on the sensory re-education and compensation strategies if needed to prevent the injury and to increase the endurance. If the spasticity exists on the patient, we do gentle stretching, range of motion, positioning, and we use some splints. However, if the patient has a significant amount of spasticity, the patient should be referred to specialized neuro rehab physical therapy for more specialized technique. Also, in the journey of coping for some of the skills that the patient has need to learn or re-educate, there are some built-up utensils and tools that the patient that can help the patient to do his ADLs independently. So ergonomic modifications to enhance the safety and the independence. And finally, the discharge criteria is we discharge the patient if they reached plateau or if the patient performed the essential daily activities independently. We focus on safety and exercise adherence, that the patient able to follow home exercise program without supervision. And the key takeaways is occupational therapy aims to maximize the independence and safety, highly individualized approach. So it's not one size fits all, and it focuses on hand function in ADLs. Thank you.
Thank you, Mariam. Continuing, we will have Dr. Paul Koljonen from Hong Kong. He will talk about surgical management of cervical myelopathy. He's a consultant and deputy chief of service at the Department of Orthopedics and Traumatology at the Queen Mary Hospital in Hong Kong. He's a Deputy Hospital Chief Executive at the McHose Medical Rehabilitation Center and the Honorary Clinical Associate Professor at the Department of Orthopedics and Traumatology and LKS Faculty of Medicine at the University of Hong Kong. Welcome, Dr. Paul. You can please share your presentation with us.
Okay, thank you, Tatiana, for the introduction. Can you see my slides?
Yes, we can. Perfect.
Okay, thank you very much for inviting me to give this talk on the surgical aspect of managing DCM or cervical myelopathy. And this is the outline of my talk. And obviously, in just 10 minutes, it will be impossible for me to cover everything, especially about the surgical technique. So instead, I would like to walk through some of my everyday considerations when it comes to treating DCM and try to help answer some questions by my patients. And I'm sure all of you encounter these questions. For example, what happens if I don't get surgery, or what happens if I do get surgery? What are the long-term outcomes and what are the complications, and so on. So we all know that the natural history of myelopathy, because of this important publication by Clark and Robinson, this was almost 70 years ago. And all of these patients, all of them deteriorate. It's just a matter of time, how they deteriorate and how fast. And we know that 75% of them will be stepwise, with the remaining being slow or rapid deterioration. And patient will ask, well, what happens if I wait and I don't get surgery? And I think this was mentioned by previous speakers in a systematic review. We can see that up to 62% of patients do exhibit some clinical deterioration in 3 to 6 years. And data from other similar studies show that about half of the patients treated non-operatively end up requiring decompression due to progression, with a mean observation period of roughly 2 to 6 years. So as Dr. Badr had alluded to earlier, there is a high rate of conversion from non-operative treatment to eventual surgery. Now, this is also interesting. I get this question a lot. Doctor, if I wait, will I get paralyzed? Now, this is quite an amazing cohort from a Taiwanese national registry of DCM, where they carry over 13,000 DCM cases, within which they found 166 spinal cord injuries within this group of observed patients, amounting to about 1%. And the authors calculated an adjusted hazard ratio of about 1.5 times that a myelopathy patient is going to get a spinal injury compared with a normal population. Along similar lines, those myelopathic patients with OPLL, they are at a particular risk. With every 1,000 patients being observed over a 1-year period, you will see approximately 4.8 occurrences of a spinal cord injury event. So, what's the best available evidence or guideline nowadays? This was published by the KF, the Knowledge Forum in Spinal Cord Injury in AO Spine, suggesting that moderate and severe cases should receive surgical intervention and with a strong strength of recommendation. This was mentioned by Dr. Badr just now. And I think this guideline does make our lives a bit easier, doesn't it? But for me, however, more and more, I find myself worrying about these patients, those with the mild symptoms or silent symptoms, those patients who come back with either a big deterioration or even worse, with a spinal cord injury. And this, I believe, is one area which deserves more research, because the quality of evidence, as we can see here, is very weak. Although this talk is on surgery, I don't think we have time to go into the surgical technique with only 10 minutes, but suffice it to say, I think there is a wide range of factors I consider when I decide between the surgical approaches. For example, the alignment, the pathology, any instability, the bone quality, etc. And here are just some examples of cases I'm sure all the experts here are very, very familiar with doing. So some might ask, so what does the literature say about the choice of approach? Is there a better approach, anterior or posterior? And the answer is Well, it depends. No one's going to make the choice for you. You need to consider all the individual factors in each patient, because both surgical approaches yields comparable outcomes in the long term, with anterior surgery perhaps demonstrating some better early functional advantages, shorter length of stay, less wound pain, and lower chance of C5 palsy. But we can see that these advantages, they diminish over time. So anterior and posterior, they equal out, with functional improvements really not consistently reaching MCID. Now, moving on to the outcomes. Oftentimes, patients are worried. They want to know, will they get better after surgery? Or some will think that they might get completely well after your surgery. And if not, they think that the surgery was not successful, something wrong with the surgeon. So therefore, it's important that we give these patients realistic expectations. And take a look at this large prospective multi-center study, which involved roughly 280 patients. And you can see this table compares outcomes amongst patients according to the pre-op disease severity. So patients with mild disease preoperatively experienced the smaller improvements in JOA score, and those with the severe disease experienced the largest improvement, although there must be some ceiling effect, with no differences between the severity groups when we consider the functional, the disability-related, and the quality of life outcome measures. So this is our own experience in Hong Kong, where we followed up our own patients post-op for a year. And the JOA scores we saw improved gradually, as expected, after surgical decompression, reaching statistical significance at 3 months after the operation and reaching a plateau at 6 months after operation, with a mean recovery rate of JOA of 55%. Furthermore, if we looked closer at the breakdown of the JOA components, the neurological recovery was always the best in the upper limb function, followed by the lower limb function, and was always the worst in the sphincters function. So this right here is how I counsel my patient nowadays, especially when they are worried why they didn't get full recovery on post-op day 1, why they still have some hand paresthesia and clumsiness. You need to tell them that there is time for the improvement to come along in months after post-op. Now, another thing is about the surgical complications. This is a global study, including approximately 280 myelopathy patients from 16 centers across the world, with a 2-year follow-up with varying degrees of severity and etiology, and it includes both anterior, posterior, and combined approaches. And you can see the list of complications in the red box, with overall being around 5 to 6%, and a combined neurological complication rate of about 3%. A special mention, though, I would like to pay to the C5 palsy, which I think is one of the more mysterious complications in the cervical spine, which is somewhat difficult to evade. When it happens, we are often quite disappointed, and so is the patient, and we don't know why it happens. There are a number of hypotheses as listed here. And here is the experience in our center. And although we found that the overall incidence of C5 palsy was 14%, the subgroup analysis showed that it was much higher in the instrumented fusion group. And I tried to use this video of my finger stuck in the door, my finger being the nerve root, and the door being the foramen. So if it is fixed, the nerve cannot move at all. Whereas if there's some movement of the neck, the nerve root can wiggle a little bit. And so instrumented fusion, especially with deformity correction, is a much higher risk factor in decompressing cervical myelopathy, up to 50% in this cohort. But the good news is all 100% of them recover by 2 years. So at least that is something you can reassure the patient, but it takes a long time. And finally, there are some patients which, despite the best decompression, never get better. So let me just illustrate to you by visually showing you this patient I operated on, a case of severe myelopathy due to OYL. And despite what I would say a decent decompression, on intra-op ultrasound scanning of the spinal cord, you can see the severe intramedullary cystic necrosis within the spinal cord due to the chronic compression. So even before I close up the wound, I knew that despite a successful surgery, these patients would still likely be left with severe neurological deficit that may persist over the lifetime. So after the surgery, how much improvement is considered good? How much meaningful improvement is important for the patient? So-called the minimally clinically important difference. And in this study by my friend Sokato, he has found that the MCID is 2.5 points and 52.8% of JOA recovery rate. And the highest level of symptoms beyond which the patient consider himself or herself as well is 14.5. So this here is a bit of a cooler for the surgeon's ego, including my own, when there is just maybe 1 point or even 1.5, 2 points improvement in JOA. But it is something useful to communicate, especially with your therapist, so that when we tailor-make the rehabilitation plan, we know where the patient is in terms of the recovery trajectory. And finally, a word on the neurological survivorship, because again, this is one of the questions patients ask a lot. How long will my improvement last? Is there going to be any recurrence in the future? So if you look at the literature, there's no good long-term data on this. And this is why we looked at this question in our own hospital, following up 195 patients between 21 years with an average follow-up of 6.5 years. And we were able to show that the overall neurological survivorship of our patient cohort was roughly 90% at 5 years and 77% at 10 years, with risk factors for neurological failure being, number one, OPLL, especially in non-instrumented fusion cases. And secondly, non-instrumented laminoplasty, i.e. suture laminoplasty, which we did a lot back in the day, and patients with pre-op cord signal change. So hopefully these can help you counsel our patients. Finally, just to mention on this resources, a project launched by a colleague of mine, Ben Davis from Cambridge, who looks at 10 priorities for the research area of DCM, and there's a lot of resources here. One of our publications, which you'll find in this report, highlights the available evidence on surgical management and also provides some discussion on areas of uncertainty, such as mild myelopathy, which I mentioned, atypical symptoms, and timing of surgery. So the interested reader can find this on an open source. And with this last slide on the learning points, I will finish my talk here. Thank you very much for your attention.
Thank you very much, Dr. Paul. Perfect presentation, very, very good. So following, we are calling Dr. Tsui Chi Mak. She's an occupational therapist at Duchess of Kent Children's Hospital in Hong Kong. She's a specialist in degenerative spinal problems, focused on postoperative rehabilitation. Please, Gigi, can you share your screen with us?
Okay, can you hear me?
Yes, yes, very good.
So thank you for the introduction. So today I appreciate the opportunity to speak with you all about my experience in functional rehabilitations and long-term management for degenerative cervical myelopathy from an occupational therapist perspective. And as many of you may know, cervical myelopathy presented with a variety of symptoms that can significantly impact on patients' quality of life. And even after surgical interventions, patients may not experience immediate symptoms relief. And before receiving any rehabilitations, they often face postoperative wound pain and functional deficit that can lead to immobilizations. And being confined in the hospital bed, All that they can see is the ceiling in the room, and even doing simple tasks such as toileting, they need to call for assistance, leading to a feeling of frustration, helplessness, and also loss of dignity. While the primary goal of surgeon is to relieve the spinal cord compressions and prevent further neurological deterioration, it is essential to understand that it is only the first step in recovery journey, and the real work starts afterwards. As an occupational therapist, my role is to assist patients in navigating their challenge and help them from being bedbound all the way to mobilizing well and to restore their daily function. And rehabilitation starts as early as patients' vital signs are stable following the surgery, starting off with restoring their functional ability through regaining their range of motion, strength, and also motor control. And from then onwards, we identify any difficulty that patients face and provide them with assistive device and home modifications that will equip them to take an active role in their rehabilitations. Also, we also provide some self-management strategy so that they can learn how to take care of themselves. And every successful journey starts with a baseline understanding of patients' conditions. Specific to functional assessment, we conduct a physical performance test, including the 10-second grip and release test, 9-hole peg test, foot tapping test, 10-second step test, and 30-meter walking test. In addition, we also carry out somatosensory assessment, including the quantitative vibrational test and also the quantitative Romberg test with the aid of motion analysis system, to obtain a more quantifiable result. Lastly, we also classified the severity of DCM using the Modified Japanese Orthopaedic Score, the MJOA. And apart from our functional assessment, patient perspective on their disability is also an important outcome measures. We also utilize questionnaires such as Neck Disability Index, SF36, Cervical Myelopathy Severity Index, and the EQ5D. And from the early postoperative stage, it is essential to get patients out of bed and start mobilizing. We place a strong emphasis in the bed mobility as well as the chair and toilet transfer. And as patients progress from being bed or chair bound, we aim to help them to mobilize using assistive aid, for example, frame, quadruped, stick, and ultimately walking unaided. And for patients with severe cervical myelopathy who are wheelchair bound, we prescribe appropriate wheelchairs and provide training on effective maneuvering. This can help them to mobilize independently and foster a sense of autonomy despite of their disability. Additionally, we also offer some outreach program to ensure that patients can utilize the wheelchair in the outdoor and also at home. And getting out of bed enables patients to actively participate in our rehabilitations. Many of our patients with cervical myelopathy experience hand clumsiness, which can significantly affect their ADLs. Tasks that we often take it for granted, for example, holding onto a frame, picking up small objects, buttoning up for dressing, feeding with chopsticks, and even writing, becoming increasingly difficult with patients due to impaired sensations and coordination skills. And in our rehabilitations, we focus extensively on enhancing hand dexterity and also strength. Tools such as pegboard and tweezer are commonly used to improve their fine motor skills as well as their eye-hand coordinations, whereas gripper and putty are effective in building up intrinsic muscle strength. Throughout the training program, we also integrate activities of daily living tasks into our exercise, for example, feeding and also dressing. We begin by using modified aid, allowing patients to practice their essential skills in a more supportive environment. And as their dexterity and coordinations improve, we gradually transition them into more complex tasks and reducing the reliance on assistive aids to foster a greater independence. And for patients with significant cord compressions and nerve root damage who experience hand deformity and weakness, we fabricate splintage to provide them support in the hand movement during ADLs. On the other hand, patients with damage to the posterior column may struggle to control their movement. due to impaired body awareness and also poor coordinations. And our rehabilitations focus a lot on the proprioceptive training. From isolating joint movement, for example, using the hand tilter to train their finger and wrist coordinations, the mini board for ankle and foot coordinations. And for those with poor truncal control, we also use the sitting system mini board to train their truncal balance. And once these fundamental skills has established, we advance to the dynamic body balance training using the core balance system to further enhance their overall stability. And before patients getting back to home, we need to ensure that they can perform self-care activities either independently or with the aid of assistive device. At the same time, we also conduct a thorough home assessment to identify any environmental hazard and recommend appropriate equipment for modifications. And now that patients are ready for discharge functionally, we also need to make sure that patients can able to get in and out of the cars for indoor and also outdoor mobility. And of course, family education is also essential to facilitate a smooth discharge. Often, family members experience more anxiety than patients themselves. And my role involves of explaining patients' conditions, including any limitations and precautions that can prevent them from falling at home. Making sure carers is also competent in bringing patients back home. And with all the hard work, patients can finally be discharged from hospital. But is this the end of our journey? The answer is absolutely no. Full recovery may take months, making it essential for us to monitor patients in an outpatient setting and provide the continuity of care. Over the 2 years postoperative time frame, we not only teach patients on some exercise to restore their functional ability and also flexibility and strength, but also to assess patients regularly to monitor their functional improvement. Additionally, we also teach patients in some self-monitor strategy, for example, using the Down questionnaire, which is easy to administer at home. And for younger patients who are still in workforce, we offer specialized training programs to facilitate them in return to work. We provide work conditioning programs that are designed to improve patient strength and capability and also endurance. Unlike traditional rehabilitation, it's specifically targeted on patients' job demand and stimulating specific jobs that patients encounter in the work, helping them to rebuild their physical capability and also boost their confidence in performing job-related tasks. And with all the time and effort, we can observe a significant improvement in patients' functional ability, as evident by the longitudinal improvement in physical performance tests, supported by the somatosensory assessment. Here we can see a progressive improvement in the sway area during the quantitative Romberg test. And of course, MJOA being the most common outcome measures, we will not overlook its significance and will utilize it as a benchmark as a rehabilitation progress. And to wrap up, while every patient's journey is unique, our mission stays the same, in which we help patients to restore their life. And every step that we take, no matter through training program, home modification, family educations, or even work rehabilitations, all bring us closer to the goal. And let us remember that our efforts not only to restore patients' physical ability, but also to reignite their purpose and hope. Together, we have the power to transform life, empowering them to return to their community and embrace their passion. Thank you.
Thank you, Gigi. Thank you so much. Very, very good. So we are moving to our final talk. It's on postoperative physiotherapy management and a case presentation by Daniel Martins Coelho. He's a physiotherapist at the Kinesis Physiotherapy Clinic in Ribeirão Preto, São Paulo, Brazil. He's a member of the EPIC, which is the Educational Research and Intervention in Spine at the University of São Paulo. Please, Daniel, can start your presentation. We already see your screen.
Okay, thank you, Tatiana. Is everything okay with the screen and the microphone? Yes, thank you a lot for the invitation. Now, to finish, we're going to talk about postoperative management. As we saw before, the surgery is one of the main interventions for our patient with myelopathy. So we have to see what happens with these patients. As said before, almost half of the patients which undergo to non-operative management need to go surgery in 3 to 6 years. So surgery is a realistic situation with our patients. Although it's a good treatment, it's remaining challenge to predict the surgery outcomes. So let's see some other surgical outcomes predictors for our patients. Age is one important predictor. So the younger the patient, the better the recovery. It means the patient with less comorbidity has more conditions to get better. Symptoms duration and severity also is a good important thing to see. The longer, the worse. Patients with 20 months symptoms or MJO symptoms lower than 12 points, it's the better scenario for our patients. Some comorbidities like diabetes and smoking are not good when thinking about surgery. As we saw in previous presentation, MRI gives some signs of spinal compression that give us some predictions of how patient can evaluate in our condition. Another thing to see is the number of surgical levels. The bigger the surgery, more difficult will be the recovery. In some patients, we see that cervical collar are used after the surgery. In our reality in Brazil, we see some patients using them from 3 months after the surgery. It's in short term, it's good because it relieves pain. But in long terms, we saw that the patients refers neck pain and decreased range of motion after the use of the spinal circle. Other thing that we see is shoulder pain with this patient, with a lot of myofascial pain for the reduction of mobility of the shoulder. And when we think about choosing to use or not to use, we see that there's no difference in fusion rates between these patients. So we have doubt in literature if it's a good thing to use after surgery. Talking about cervical range of motion is one of the main things to see in patient after surgery. It's normal to patient to get reduction range of motion because we get some fusion levels, and it's a good point to give some attention. One of the most important movements to see how patients get recovered after surgery is flexion and rotation, because they are one of the most functional in our daily living activities. I have one patient that was submitted to a surgery here in our service. We see that he had a C3 to C7 surgery and used 3 months of neck collar. And this video were made on the moment he took the cervical collar. So we can find out how the amplitude of movement of this patient. We see that he got almost 45% of cervical rotation using principally C1 and C2 movement, which we need to know this biomechanics so we can try to get that with the patient. In flexion extension, we see a reduction movement because C3 and C7 are very important for this movement, but it has a functional range of motion that we can use with patient. And besides range of motion, we need to see how muscle function after the surgery. We know that muscle endurance in patients with pain and head forward posture have difficulty with endurance. And the same thing happens when patient gets cervical fusion. These muscles get worse injuries. And what happens when the patient doesn't have this muscle working properly? We see that it may alter the spinal biomechanics and increase the risk of developing adjacent segmented degeneration. This is that important thing that we saw after spinal surgery. Adjacent segmental degeneration is a condition that is not clear in the literature if it's a natural progressive of degenerative or it's a consequence of the cervical fusion. We see that almost 28 patients after spinal fusion have adjacent segmental degeneration, with 13 being symptomatic and 5.78 needing to go to reparative. What we see in these patients that the muscle is very low with the endurance function. So we think that training, extension, and flexion endurance may help to prevent and to recover patient from adjacent level degenerative condition. What we saw in rehabilitative program after surgery fusion is that the earlier we started, the better. In literature, we see that 7 days to 3 days, 2 weeks initial programs get good results without putting patient in risk of losing their rates of fusion. What we do in this phase? We start progressive muscle exercise with initially with no resistance, so we progress to isotonic. Another thing we can do in this phase is start with small range of motion of almost 15 degrees, progression to almost 45 degrees of rotation and flexion, so that the patient can progressively going to almost the range of motion we will get after surgery. Another thing to work is postural, because we saw that bad posture can change the others level that didn't have fusion, preventing further degeneration in the spine. But we have to remember that besides this rehabilitation, we're talking about muscle and range of motion after spine surgery, we need to remember that the patient had previous aims in the rehabilitation, like we saw in the previous presentation, like gait deficit, motor control problem, pain, that this all needs to be thinking when we're rehabilitation our patient after surgery. The learning points in this presentation is that postoperative is a new condition. Think about the cervical function. But the body needs to remember that we had the same condition before that will get better, as we saw almost in 3 months of rehabilitation. We need to give attention to spine's mobility and muscle function, and think about a global and individual rehabilitation for our patient. To finish, I have 2 cases to discuss, to bring discussion for the end of this meeting, is that 2 different patients. The left one is a patient with 30 years old that had a traumatic myelopathy. And the right one is a woman with 62 years old that had degenerative myelopathy. What are different in these 2 is not the MRI. We see that what happens there is that the left patient has pain and neurological signs, but he doesn't want to get surgery. He's trying the conservative management. while the right patient has no signs of pain, radiculopathy, or any neurological sign. It was discovered in a casual MRI cycle for the doctor. The things that brings me this moment is the left one doesn't want to have surgery, besides the doctor said he needs to. And the right one, even with no signs, the doctor wants to operate. What brings us the discussion what Dr. Paul brought us in his presentation. What patient needs to be operated? The left one or the right one? And how can we think about the future of these patients? So that's the discussion I want to bring with these different patients, and thank you for the invitation.
So thank you very much, Daniel, for your excellent talk. And also I would like to thank all the speakers who have performed a very excellent presentations, from diagnosis to various different kind of management and rehabilitation of the condition. So, but unfortunately, we are a little bit short on times. So maybe we can see whether the speakers here have any comments on the cases just mentioned. Or Daniel, would you like to mention something about the cases again?
Yeah, one important thing, I think the right case, the patient who has no sign, is very afraid of doing a lot of things because the doctor said, if you don't do the surgery, you can get neurological dysfunction very sooner. She's afraid of driving cars, of moving her head. So it's very difficult to relate with this patient. While the other one who has sign isn't afraid of anything. He can do everything and he thinks everything will be okay.
Any comments from the other faculties or any questions? You can just unmute and say something if you want.
Yes, Daniel, I completely agree with your concern, and this is a real life situation. We have because now with the relative convenience of getting scans, we do have patients with very mild symptoms, such as your second patient on the right, having radiologically significant stenosis, even in this case with already cord signal changes and myelomalastic changes, who are relatively asymptomatic or even completely asymptomatic. But my concern, like I raised is in the talk, is what happens when they do have a significant deterioration, or if they have an accident and end up with a severe case of spinal injury. And this is what we don't want to see. This is an area which has very poor research and it's very relatively weak area of evidence. I think it is a problem that we all share.
Yes, and there is another point that I didn't said. The doctor who saw the patient didn't do a physical evaluation. He just saw the image and said, "You need to go surgery." That's a problem with her. I said, "No, you have to be evaluated." I did evaluation. He had no signs, no neurological sign, no Babinski, no Hoffman, nothing, and just the image. She went to another doctor, and he did the same thing. He just saw the image and said, "You need to go surgery again." And she's going today, I think about right now, she's going to a third doctor to see if he evaluated and give some objective treatment of patient.
Unfortunately, due to the time constraint, maybe I should convey a question from the audience to all the faculties. So from the audience, we have mentioned about the importance of early treatment and diagnosis. So what are the earliest symptoms and signs that we can appreciate? And is there any prognosis score for this cervical myelopathy? So anyone would like to?
Yes. So
Yes.
basically, anybody starting with a cervical spondylosis before myelopathy, they complain of neck pain, sometimes radiations, which is cured conservatively by physiotherapy or small short-term treatment or small medicines or neurological medicines. But at the age of suppose 50, those who have no relief and complaining of severe pain, not responding to therapy. So these are the cases we basically think about the surgery. Those are not recovered. And the earliest symptoms, suppose somebody develops neurology, any neurological signs and symptoms, no doubt they are the candidates for any surgical intervention or early signs symptoms for cervical myelopathy surgery. And regarding this prognosis scores, there are two scores also for the prognosis score, like one is Japanese Orthopaedic improvement
speaker who have spoken tonight. And please fill out the evaluation for this event. And we hope that we all learn something tonight, and we will be more confident in managing our patient with cervical myelopathy. And also, you're welcome to join the following event, which will be held shortly later by SICOT. Thank you very much.